All right, welcome folks, and good morning. My name is Joelle Simpson. I'm the Medical Director for Emergency Preparedness here at Children's National, and I'm very, very excited to invite and welcome my colleague from Harvard Medical School, Children's in Boston, to speak to us about an issue that is very important, very current in the news. Dr. Sarita Chung is the Director for Disaster Preparedness in the Division of Emergency Medicine at Children's Hospital in Boston. She's board certified in pediatrics and pediatric emergency medicine, and she's actively involved in all aspects of pediatric emergency preparedness and response, including research, teaching, and clinical care. She is the principal investigator for the Emergency Medical Services for Children's program, and of a targeted issues grant to develop the original novel image-based family reunification system, which proves to be effective and has presented this work in national forums and peer-reviewed journals. In terms of teaching, Dr. Chung is an assistant professor at Harvard Medical School. She is an active member in the Disaster Preparedness and Advisory Council for the American Academy of Pediatrics, and is on the FEMA National Advisory Council. She's also been on the American Red Cross Scientific Advisory Council, so she certainly knows her disasters. The thing that she's most proud of, and probably most important, is she's the mother of 3 beautiful children. She says that that itself can be a day-to-day disaster, depending on how you look at it, but I'm sure they're her pride and joy. So, Sarita, Dr. Chung, welcome.
Thank you, everybody. Can you hear me? I want to thank Dr. Simpson for inviting me to this Grand Rounds. It's really an honor to be here. For those of you who are observing Yom Kippur, I was told I should say, and I hope I mess up the pronunciation, but Gamar Hatama Tova, may your life be sealed, may you be sealed in the book of life. So thank you for coming. I'm really excited to talk to you about this topic, family reunification after disasters. And as Dr. Simpson said, there is a lot going on right now. And the key question for us is, have we made any progress? So I have no conflict of interest, but I steal from the internet, so you will see a lot of images from the internet. My objective is to discuss the importance and challenges of family reunification planning, to present the current systems and resources available, describe results from family reunification research, and really think about next steps with you. And just want a show of hands, how many of you have actually been involved in a disaster or know a close colleague or friend that's been involved in a disaster? Raise your hand. So there is some, I think probably around 50%, and I think we see that more and more, so that we know that disasters are increasingly occurring. For example, last week, Hurricane Florence which decimated my home state, North Carolina. But children will always be a part of this. Children will always be a part of disasters. So the upper left is chemical attack in Syria. The upper right is the school shooting in Parkland. The lower right is the Tennessee bus crash, which injured 30 kids and killed 6 kids. And we're going to talk a little bit about their experiences because I think it's very relevant to us. And then this last photo is from actually last week, Hurricane Florence, where children needed to be rescued from their homes. The hallmark for us, and when we think about family reunification after disasters, is Hurricane Katrina. Hurricane Katrina represents many different things, but for us, over 5,000 children were separated from their families. And it was due to the rate of evacuation, but also probably miscommunication. And so there was no plan that we were going to separate children from their families. And so there was no plan to reunite the families, and there was no tracking done at that point. And so really, there was a non-governmental organization called the National Center for Missing and Exploited Children that really helped the federal government, went down and tracked all the kids, and finally the final reunification was 7 months later. So the last child was reunified with their family 7 months later. And you can think as a family member, that's really tough to be without, you not know where your child is until 7 months later. We know that there needs to be plans for school reunification. You're here sitting at this talk, thank you very much, but your children are probably elsewhere. And so there's an estimated 55 million children in schools and child care facilities during the day. And so do you know your children's school emergency plans. Like, if they're going to be evacuated, where are they going to be evacuated to? And those plans need to be integrated into the local emergency management planning. This was the ice storm in 2014 where I think DC doesn't do well with ice. Atlanta probably does worse with ice. And so when that ice storm came, most children had to shelter in place overnight until the ice storm was over. For hospital reunifications, the Boston Marathon brought it closer to home for us. And so this is our local newspaper. The Boston hospital is confronted with challenges in identifying patients after a marathon bombing. This was especially true in our adult hospitals. So one very well-known hospital, who will remain nameless, actually led a family to the wrong patient. And that family, actually, their member was actually one of the deceased. And so you can imagine how much grief that family had to experience. First, the joy of thinking that their family member was alive, but then later knowing that they were not. For us, we had a mother that walked to 3 different hospitals before finding out that her child was at Boston Children's. She was running the marathon, and her husband and child was waiting for her. When the explosions went off, she promptly stopped, and she walked to many different hospitals. And I think, you know, it is a chaotic scene. Anytime you have the start of a disaster, it's going to be very chaotic. But maybe we didn't have to have her run, you know, walk to 3 different hospitals. Boston is a small footprint, but still, you know, just think of the anxiety as you go to each hospital and not know where your child is. And I think in DC, there's special challenges for family reunification. You have a high tourist volume, so everybody wants to come to DC. All your middle school people want to come to DC, and they are coming with chaperones and perhaps not all their parents. So if there's an event, you will be communicating with parents that may not even be in this state. You have a large international population, so whatever plans you need to have include embassies. That's actually a challenge we had in Boston, where we have a lot of consulates, and the consulates were asking hospitals to see if their citizens were there. And we did not have a mechanism to share that information at first. And then pediatrics. In Boston, we are a little bit of an embarrassment of riches. We have 4 pediatric emergency rooms, and I think you only have 1 here, and you're it. So you will probably receive most of the children, and need to be organized around that. So we all think that family reunification is important and is needed, and so many of the large governmental, non-governmental organizations have issued policy statements. And one thing that they realize even to this day is that we really need improved methods for unifying separated children with their families. And we really, this is from the National Commission of Children in Disasters, we need to develop a standardized interoperable national evacuation tracking and family reunification system that ensures the safety and well-being of our children. And this is our holy grail. Like, you know, we really need to find this system. So what are the challenges of children regarding reunification? So developmentally, and I'm speaking to a group of pediatricians, so you know this, but not all emergency managers know this. Our public health colleagues may not know this. So developmentally, you know, if they're so scared or if they're young, they may not self-identify. They have immature cognitive skills, so they may not be able to communicate with you or understand exactly what's going on. We all know the mental health risks after disasters. So if you do not intervene immediately, if you do not provide a safe environment for the child, there is lifelong risk of mental health disorder. And then safety-wise, I think you know all this in pediatrics, but you can't just throw kids in a room and say, that's okay, you know, go to it, we'll keep you safe. You really need to think about child-proofing the room. How are you going to protect the children? Takes a lot more staffing, and so when you're in a disaster, things are overwhelming and you have scarce staff. How are you going to manage those resources? And you need even more space than you can imagine. And then let's talk about the families. So family expectations of what happened during a disaster. So the first assumption is that families will obey evacuation instructions. So I'm just going to ask a question to the audience and raise your hand. So suppose your child's school is in a danger area and they told you, you need to evacuate the city. Don't worry, we'll take care of your kids. How many people are going to obey that evacuation order? Raise their hand. Okay, nobody. So you are actually also in the agreement. So there was a study that showed that 63 families would disregard that evacuation instruction. And so that's not in the local emergency manager's mindset that people are actually going to actively disobey evacuation instructions. Families also expect all hospitals to have a plan to reunite families. The reality is, when we look at the large survey of emergency departments, only 47% of emergency departments in the U.S. report having a disaster plan that addresses children. So they probably don't have a family reunification plan. And then families also expect immediate identification and reunification of all survivors. And so guess what? You're not going to have that information. So identity of deceased victims sometimes takes days, sometimes takes weeks, depending on the incident. And so what happened at the Tennessee bus crash is that all the injured children were sent to one hospital, and the deceased stayed at the scene. But they told families that all children were at the hospital. So there were many families that came and said, why don't you have my child? What are you hiding from me? And it was very hard for these hospitals to come back because, you know, I think as time goes on, you gradually realize, oh, maybe they are deceased, but you don't actually have actual confirmation. And so it's very hard to comfort those families. So you need to have in your programs expectations that, you know, you may not have all the information and be able to convey that to stressed parents. And so now I'm going to switch gears and talk about current systems and resources available. On the federal level, I think knowing that this was a hard topic to digest or start, FEMA, along with non-governmental organizations, came up with kind of a framework. So the post-disaster reunification of children, a nationwide approach. So this supports overall reunification process and procedures. This is more emergency management heavy. It identifies roles of leads and supporting agencies from emergency management point. It enhances reunification elements in the emergency preparedness plan. And it just provides a general approach for schools, shelters, and hospitals, but it doesn't do a deep dive. But this helps hospitals and schools understand what is the other side, how can we integrate with our local or regional emergency management programs. On the federal level, there are registries that you can participate if there is a disaster. So FEMA has the National Emergency Family Registry. There is also apparently a national mass evacuation tracking system that they say they have. I'm not sure they've ever used it, but that's what's also in the document. And then the Department of Health and Human Services, if there's medical patients that are being evacuated, they have their own tracking system. They also most recently have a great resource called Ask for Tracy, where if you wanted to Google that any kind of disaster topic, including family reunification, they will provide you with all the resources. So you don't have to go and look for yourself. They've actually collated and went through subject matter experts to say these are the resources that you need to read. The Department of Homeland Security actually have also developed this rapid DNA test, and I think this is what was used for the border crisis, but you just do buccal swabs, and supposedly it provides fast reunification of biological parents. I think what we found out is there's probably one in every ME's office, so there may be one in each state. We've been trying to integrate that into our state family reunification plans. There's a little resistance because there's only one. The caveat is this is not going to solve all family reunification, as we know that there are children who are adopted and children who are foster care, and you may encounter some unpleasant surprises if you use this. So you just have to use this with a little bit of grain of salt. On the national level, so I mentioned the National Center for Missing and Exploited Children. They are a phenomenal resource, and they have teamed up with the federal government. The National Emergency Child Care Locator, they're participating in that. They also have an unaccompanied minors registry that runs in the background 24/7. And so if there was an event, you can immediately log onto them. And if you have unaccompanied children, you can log into you can kind of index those children in this registry. The challenge for us as practitioners is that it's not a two-way street. So you can give information. It's really hard to get information out easily. I think they do have some controls in place. So you'll be talking to a person, but I think that part has yet to be developed. And they have this resource called Team Adam, which is the deployment of retired law enforcement officials who really know how to interact with children and also how to try to find the children and try to make the matches. So they are a great, actually, federal resource. American Red Cross also has a website that you can log on and interact with and to track unaccompanied children. If they do have unaccompanied children in their facilities, they've designated 2 people to supervise that unaccompanied minor. And then social media. I think social media is now playing more of a role in disasters. And so how does it play a role in this scene? You know, first in Facebook, when there was the Haiti earthquake, there was a lot of, have you seen my friend? There was a lot on Facebook that you can immediately interact. There was chat rooms that were set up. Currently, there is an application where you can mark yourself safe so that you know your family members know that you're safe. Twitter is also becoming more used to ask for help. This was a tweet from Hurricane Florence where a friend knew that somebody was stuck in an attic and was tweeting out to anybody to see if they could save their friend. There's also an app that was developed by the National Library of Medicine that also speaks to family reunification. So I think people are out there thinking of solutions. Not any solution is perfect, but I think people are taking advantage of local or leveraging technology to really think about how can we solve this problem. On the state level, this started in New York, but now has spread to other states where they go into schools and you can opt in to get a Safe Child card where they have a picture of your child and fingerprints of your child, so you can carry that around. And in Louisiana, they have coded armbands, so that's what can happen at the state level. We're still at a loss at the local level, so there's no standardized approach to thinking about how to track patients and how to think about reunification. I think everybody has a plan. If I ask your DC emergency manager, they say, oh, yes, of course we have a plan. In Boston, they're like, oh, yeah, we totally have a plan. And I will challenge you to say, does it really fit the needs of children? Because it doesn't. It may not. And so for us to think about family reunification, we need whole community involvement. For the deceased, we have some protocols in place, or we have protocols in place with local dental records, police departments, and DNA and fingerprints. But here are some shortcomings. You can't access the FEMA national systems unless there's a federal disaster declared. So even though there may be a disaster in your local area, you can't have access to it unless your governor says can you help us declare disaster? And what's more, all these systems that I just described, how many people think they talk to each other? Yeah, this is like, your EMR records, like from other places. So they don't. We haven't figured out a way to really have that integrated approach where they talk to each other. Social media requires that you're alive, you have internet access, and you're literate, or you're able to post pictures. And the challenge is that our local systems may not be scalable or remotely accessible and may not integrate into the regional plan. And what is not addressed that we're so concerned about? So doesn't address people can't access the system, so very young children, pre-verbal, children with special health care needs, those who are severely injured or deceased. So we thought we would try to come up with a solution. And so, keep in mind, this research was done right after Hurricane Katrina, so I think there's been now more technology that can be used and that we can think about integrating. So we said, we saw what happened at Hurricane Katrina, 5,000 children lost. How could we have made that better? And so what our thought is, we were going to develop a system where there's a disaster and then there are missing children from that disaster. What we thought we would do is that we would take photographs of these children. We would integrate it into our system where we called it Reunite. It's not very original, where we would extract their facial features, so their eye color, their skin color, their age, and gender. So that we know that during a disaster, you just don't have the staff to be cataloging children. And so how can we totally make this more automated? And then when families came in, they would just give their descriptions of their child. Johnny is 10 years old with brown hair, blue eyes, and we could input it in the system and hopefully facilitate a faster reunification. And we talked about this in our peer-reviewed journal. So where could the system be accessed? We thought hospitals, healthcare centers, relocation centers. We thought, how can we integrate it across our whole community? And in order to think about a system, we said, before we actually even create a system, let's see what the emergency responders think would be needed in a system. And so what we did is we surveyed emergency management responders, some of them hospital-based, some of them local emergency management, and said, we were thinking hypothetically of creating a system to help with family reunification. And what we want to do is we want to take a picture of a child, extract their facial features, and have the parents come tell us what their child looks like and see if we can find a match. And we wanted to ask, what kind of database do you think we should have, and should we have edited pictures or not? So we asked, how many pictures should we show parents? Should we show parents just ones that all characteristics match? If most or some, or don't attempt any matching, we should just show all the pictures. And it was interesting, I think there was understanding that not any system is perfect. They said show only pictures that if most of the characteristics match. Those 10% said, I think this matching idea is a bad idea, just show all the pictures. And then we asked the emergency responders, what would be most useful when you show the pictures? Because we were imagining that children would have trauma. We thought it would be very stressful for parents to look at pictures with trauma on it. So we said, what if we edited that? What if we could clean it out, make it so it doesn't look like that? And I don't know how many of you who have done research where the people back to you say, this is the most horrible idea ever. How could you think of this? And that was our response. We were like, whoa, we really hit a nerve. And so what they were describing, and somebody actually came up to me and said, almost in tears, this is deceitful. And I was like, I totally didn't mean to be deceitful. I'm really sorry. But this is like the version of fake news. What they thought we were doing was that if we edited the pictures, then we're showing an unrealistic example of their child, and that they would be further devastated if we had told them later that this is not what their child looks like. So I think it was good for us to think, we were thinking in terms of how can we not stress out the parents, and the emergency responders said in a subsequent question, we know that looking at traumatized pictures are stressful, but we would still want that over edited pictures. We also asked them, what's the minimum percentage of reunification that would be needed to warrant adopting a primary system, a system? How many people do we need to reunite so that you will adopt this as your system? And we talked about it in a small-scale disaster, so just 10 people, or 100 people, or 1,000 people. And on the x-axis is the minimum percentage of families reunited to warrant adopting this system. And then the y-axis is the percentage of emergency management professionals. And what we found is in a large-scale disaster, if your system could only reunify 10% of families, over half of the emergency responders would adopt it as a primary system. This is a really low bar. It's like on an exam, if you get 10%, we would accept it. But I think it goes to show that we don't have a system right now, and so that's why it's important for us to think about creating a system that would facilitate family reunification. And so then this was a really neat project because it was very multidisciplinary. We teamed up with computer scientists who have a very different view and an anthropologist. And so when we developed our system, what we did is we had 4 features. We were able to extract skin color, but later, based on how the algorithm worked, we divided it into 2 categories. We tried to divide up into eye color, age, and gender. So that's what our system could automatically extract. And then the computer scientists added in a bonus, which we didn't think about, but they said, we have this similarity user feedback algorithm. So you can look at you can look at a bunch of photos, and you can pick ones that look like your child, and then we'll reorder the database based on your selection. And I think the advantages is if this is a large-scale disaster, if there's thousands of pictures, you can hopefully cull it down more, or if it's a homogeneous population, say you're in China, where everybody has the same hair color, and most people have the same hair color and eye color, then that may give you an extra way to try to call down and see the pictures in your database. So this is an example. So this is a missing child. What you do is you would pick children that are very similar, or you felt like very similar to your child, and hopefully that would provide you with a faster match. So we use that to test it in a large-scale disaster drill. So we really incorporated the whole emergency management community at our hospital, the committee at our hospital, and we said, you know, we want to see how the system would work, but really we want to see how our protocols would work. You know, so with managed social work, child life, psychiatry, you know, how can we design it so we can provide a safe area for the children if those children are medically cleared and will need to be in a safe area so that they're discharged from the emergency room. How can we provide things so that, you know, what would it take for us to have parents go through our system? So our drill scenario was that it was a Category 4 tornado in Massachusetts, and the year prior we had actually had a tornado, so we thought that was reasonable. And we had 1,200 children that are affected and are being transported to different area hospitals. We had a database of 1,200 children. The drill assumptions that all the children were unaccompanied and that children participating were unable to provide any personal information. And I think this is key. I think whenever you do a drill, you have some assumptions that may not reflect reality, but we wanted to test the extreme where, you know, what if these children were not able to provide any personal information at all? So these are kind of our results, the characteristics. We had 22 families come, 28 parents and guardians interacted with our system. This is the challenge when you ask your friends to come help you with a research project. 97% of them had a 4-year college degree or more, so it's probably not reflective of the whole United States. We actually had 49 kids participate, and 41% of the searches were for children less than 5 years of age. We identified many successes, but we also identified some gaps. So really, social work was in charge of the families or the parents. Child life was really in charge of the children. They interacted well and made sure that each family, everybody was non-stressed. Children had a great time. My kids keep asking when we can do another disaster drill like this. It was a party in that room with pizza. We really, really thought about how we're going to do an age-appropriate pediatric safe area for all ages. And when you do a drill, you never know who's going to come, but I guess there was trust in that, you know, we had a 3-month-old come and we had a 1-year-old come, and they just said, take my child, or maybe they were tired. I don't, but, so we had younger children participate in the drill, and we established the parent-child verification process. We did identify many gaps, so these, the baby and toddlers, they actually hated being in that space. It was really too loud for them. And so there needed to be one-on-one staffing to make sure that they were comfortable, and we had to take them out of the space. We actually also had a state emergency manager come evaluate the drill for us. So his goal was to be in the pediatric safe area. And this is a very smart person, younger, but very smart person. And at one point from the drill, he stepped out, and I was like, are you okay? And he just looked overwhelmed. He's like, I really need to get out of that room. That was so loud. I can't be in that room. I just need a moment to think. And for us as pediatricians, we were like, what noise? That's totally like our normal day. But I think it's really important for state emergency and local. If they're going to be running the shelters in your state or thinking about it, you can tell them that children are different. But for them to have the experience that and say, oh my gosh, maybe the space that I planned should be a lot larger, then we that was a win for us to kind of help them understand that. And then we understand that this process is not a one and done, is that you constantly need to train. You're going to have turnover, but you also need to train your new staff to be able to understand the processes. This is just an example of the vetting form. Of course, I recruited my family, so now you know all the personal demographics of my family. But so the parents filled out the form on the left, and the child life specialist asked the children questions that they can answer on the right. And what we noted from these family vetting forms that we couldn't research scientifically was that, but most children knew if they had a pet or not, and most children, even young as 2, knew what their pet's name was if they did have a pet. So I think that's a question, the vetting question that could be integrated into your plan to really verify parent-child relationship. And then, you know, did our prototype work? That was the main thrust of this also drill. And so on your right is just a graph of random. So if you randomly put pictures in and then asked families to try to take a look, their pictures would probably show up around 50%. That's just how randomly it worked. And so what we showed with our prototype is that we were able to greatly reduce the number of pictures seen in the database. So the way our protocol worked is that once your child's picture appeared, we actually stopped the program so that you would not have to see the rest of the picture. And so for us, we thought this was a win. Hey, look, this is really significantly different than random. We've really reduced the number of children being seen until your child appeared. You know, our facial extraction features may not be perfect, but it works. And our similarity also, the user feedback, you know, it was great. We really pat ourselves on the back. This is awesome. But what we also realized in the drill is that parents missed identifying their children 9.5% of the searches. So they actually, there was their child's picture on the screen, and they didn't see it. And they would have passed it, and they would have gone through all the database had we not stopped it. And so you ask why. And so I'm going to turn around and ask you a question. How many of you, as parents, have lost their child in a public space? And then, or as a child, how many of you remember being lost? So raise your hands if that has happened. So there's a large majority. And so how did you feel when that happened? Terrified, pretty bad, yeah. So we unwittingly set parents into that terrified state. So even though what parents told us is even though we knew their children were next door, having the time of their lives, just the thought of this process of looking for their children made it very stressful. And they really were having a hard time. And then the more pictures they saw, their confidence was dropping. And so I think that just goes to show that this is not the holy grail answer. This probably could help supplement, but parents are going to be so stressed that they may not be able to fully cooperate with any system and that you may need other social support to help them. And so I'm going to turn around and say, well, you know, parents would be users of these systems. What information are they willing to share, and who will they share it with in order to facilitate family reunification? And so, you know, there's a lot of political divide in the nation, and so we decided to pick a very red state and a very blue state to run the survey. So we chose the pediatric emergency room in Missouri and Boston Children's Hospital. And this was a convenient sample of adults presenting to these 2 emergency rooms. And we basically asked them, what are you willing to share if there was a, you know, there was a disaster, you're separated from your children, what things are you willing to share, and who do you trust? We had over 300 respondents. And so for willing to share, parents were, there was almost universal, despite your political divide, families are fundamental. So you're willing to share to reunite with your family. Actually, only 4% of people, 4% surveyed said they're not willing to share anything, which was a little surprising, but there is some trust. So more people were willing to share descriptive features, so birthmarks, piercing, tattoos, hair descriptions, skin color. When we got to actual photo of the face and video and DNA, they were less willing to share those features. So I think when you build a system, you have to respect, and if you ask for video or even if I thought the DNA, the rapid DNA, that Department of Homeland Security, they may not be willing to share that with you, so may not be relevant. And who did they trust? Well, you're it. So hospitals, they trusted hospitals more than non-governmental organizations such as the National Center for Missing and Exploited Children and Red Cross. But look over here. Local government, public health, state government, federal government, that is much lower on the totem pole. So even though we have these federal resources and registries, parents may not trust them, and so we have to think about how do we build a system that will integrate the most trust. Now, There are limitations to the survey. We did it in a pediatric emergency room, and so maybe that's why they said they trust hospitals more, and so maybe you need to do it in another setting, but this is the data that we found. So now I'm going to turn to next steps. So this is kind of a conversation with everybody. What are the next steps in family reunification after disasters? What can we do? Well, I think for our families and for you, for pediatricians, to talk to your families about family preparedness. And sometimes that can be overwhelming. Everybody has 10 things on their plate. I bet you have your checklist right in front of you. Right after this talk, you have to do this, that, and the other. But really to sit down with families and say, you know, do we have a family preparedness plan? The American Academy of Pediatrics came up with a family preparedness kit. And this is, you know, one of the main things is to really think about a communication plan with all your family members. So now that we all have smartphones, you can easily say, call Renata, my daughter. But do I really know her phone number? So, because in case I don't have the phone in a disaster, can I call it? And so really just trying to have all your family members know the phone number. So whenever we get into a car and do a drive, and we live in Boston, so we don't drive a lot, but my kids roll their eyes because I say, you know, what's dad's phone number? What's mom's phone number? And now that the teenagers have phone numbers, what are their phone numbers? So everybody remembers, on the top of their head, everybody knows their phone numbers. We also have had an out-of-area emergency contact person. So who are we going to contact? You know, if we can't get a hold of, you know, each other because of the disaster, you will have more luck getting in contact with your aunt in Nebraska than maybe people on the ground. So who, you know, what is that phone number? So we've had them memorize that phone number. We also know during disasters, texts are actually more efficient. So, and this is talking to the older generation. So we got my parents to start texting 2 years ago, and it's totally changed their life. But you want to make sure multi-generational that everybody knows how to text, are able to do it. And then for your young and nonverbal patients or family, for children, you know, if you're at a major event, something to do is just to take a picture of them prior to going to the event, so you actually have a most up-to-date picture. I feel a little bit of pride that I do preparedness work and that it's filtered down to my children. So whenever we go off to a major event, my 12-year-old always writes my phone number on my 5-year-old's arm. And so this is just this past month. We went to Hawaii, and so Calder wrote my phone number, and nice description, call is lost, you know, on the arm. So that, you know, just in case Archer got lost, that, you know, somebody would know to call. So I felt a warm, fuzzy feeling that this is now penetrated to the next generation. For those with special health care needs, we want to think of an ID card, either a bracelet or a necklace, and maybe it may not have all the information, but have it linked to a web cloud or a cloud, something, a web space, or, you know, so that we can get more information on the medical care. So really, as pediatricians, and also if you take one thing back from this talk, is really go back to your families and say, let's just think about a communication plan. Let's make sure everybody knows their numbers, and I would be so happy. My job would be done. The second thing, you know, other steps, well, this just came out in September. We're very excited about it. So we know that there's a gap in hospital family reunification plan. You know, it's very hard to wrap your head around. And so what we did is that we created a subcommittee of the American Disaster Advisory Council, and a reunification subcommittee. So we gathered up all subject matter experts across the U.S., including federal government, including states, and representing healthcare coalitions, and came up with a kind of a tool to help hospitals think about family reunification. This was then further developed by the MGH Center for Disaster Medicine. We received a grant to do this. It was vetted by 2 stakeholder groups in Missouri and Massachusetts. And then currently we're pilot testing it in community hospitals in Massachusetts and Missouri. So this is something that if you have local hospitals that need help with family reunification, this could be a tool you could provide. And what we do is we go step by step. We say, you know, if it's from the beginning, you know, these are the key hospital departments to have in your planning. pediatrics, family medicine, child life, on-site child care and security, as well as nursing, social work, emergency medicine, emergency management, legal counsel. So that may be your key group to start off with, and understanding that not everybody has pediatrics, and so that's why we have to include family medicine. And then once you have a formulation of a plan, then you need to invite the whole hospital and really other key players in the group, including public affairs, risk management, psychiatry, telecommunications. Health information management is very useful for patient tracking. How are in your system, hospital system, are you going to track all the disaster patients? And then really taking into account the front desk, they're going to receive the brunt of the call. So how do you train those, or how do you want to train those to really be able to calm the parents, but efficiently and effectively transfer them to other, to your response line? Food is always great. Food always calms people, so definitely include them. Every time we have a drill, and even if it's not a drill, we have many incidents where we've had classrooms of children come to us because there was an exposure at school or things like that, and you can see the stress level is high, and then once you give them food, it comes down. Chaplaincy, interpreter services, and family advisory groups. And then we have to test. We have to say, we really need to test these plans, and we really need to use children in the drill. So I just can share one story. In Boston, we had a drill at our Logan Airport where we're going to have 2 airplanes fly. And we had a group of Boy Scouts that were designated to come to our hospital. And so we're very excited. We're more than a few years ago, but we wanted to test our system. So the Boy Scouts were initially on the bus, ready to go, but then the drill people said, no, everybody has to be on the airplane. So all the Boy Scouts got into the airplane, and then that's when the chaos ensued. And so what happened was they just started grabbing kids and just putting them places. So they grabbed 5 kids and put them in an ambulance. And one of the fathers of another Boy Scout said, those are not my kids, but I don't know where you're taking those kids, so I'm going to go with them. So they made it to our hospital, and the father was actually pretty frantic. This is before everybody had phones, and said, I don't know where my kids are, but I didn't think it was safe for them to go with these ambulance people. And so we were like, no problem. The boys, everybody's planning to come to our hospital. Just wait here. So we waited and waited and waited. And finally, in the middle of the drill, they were like, does anybody know where the Boy Scouts are? Because nobody knows where they are. And so in that drill, it's a little infamous, but we actually lost the Boy Scouts. And so I think that's just, you need to understand. And of course, there were the Boy Scouts, and they don't know how to give directions. And so we found them. They later came back to the original site, to the airport. But that's a moment of panic, and that was a drill. So I think you really need to use children in your drills to understand the challenge you're going to have. And so understand and mitigate those barriers. You want to drill the entire process from separation to reunification in the whole community. And sometimes we do drills to make ourselves look good. I think, you want to plan a perfect drill so your hospital leadership goes, oh man, we fully have this covered. But I think you want to go to the breaking point. And I think don't be afraid if your assumptions were wrong. We know actually that what we assume, like family members will come to hospitals after disasters. We now know that family members will come in the hundreds. So do you have spaces? So at the Tennessee bus crash, they had 800 family members, friends, come to that hospital looking for their loved ones. For 30 kids, they had 800 people. After the Las Vegas shooting, one hospital received 500 family members. So in your plans, you have that much space. We don't have it in Boston, hundreds. And so but you need to think about that and see what would you do if you had hundreds of people coming to your hospital to look for your family members. And finally, future research in this area. I think this is to everybody. You may have ideas on how to make this better, and I think we would welcome it. Some ideas include leveraging social media for child identification. Now that we have so many people posting on Facebook, Instagram, is there a way to leverage that technology to provide a sooner child identification? Are there better imaging-based family reunification systems? Are there best practices for regional family reunification plans that include children? Are there other biometric systems? And really, the ... is for you. You may have an idea that may be awesome that we need to think about. So please, if you contact me, I'd love to talk about it. But I think this area we're still here. And it's still right that we just don't have the answer. So in summary, have we made any progress? Family reunification after disasters. And I, didn't address the elephant in the room until last minute so that I wouldn't get any questions about this. But the border crisis, we've come from Hurricane Katrina now to the border crisis. And so I would say, as with many things, this is a marathon, not a sprint, and that we've made some progresses. One of the things we probably really should do is make sure our hospitals are prepared for family reunification and that our hospitals are working with their regional coalitions or local emergency management to make sure that their plans are integrated into the whole scheme of things. We really need to advocate for kids and knowing that the unique needs of kids that are integrated into the family plan. But I think we still have a long ways to go. And so I think, thank you very much for attending. I just want to acknowledge that this is not my work. This is work of many people. It takes a village. And so those at Boston Children's Hospital, the AAP Disaster Preparedness Advisory Council, and my former mentor who really started this work. So thank you very much.
I have a question, Sarita. So one of the issues we've thought about and has come up during our drills is really the idea of the laws like HIPAA and those sort of things that we often are hindered by in terms of just openly sharing information. Have you thought about that in your plans or drills, and how have you guys dealt with it?
So I think when it comes to disasters, I think HIPAA is a little bit more lenient. That being said, sharing information, I think having that understanding of who you're going to share that information with beforehand really helps. So in some hospitals, it's American Red Cross, you share the information to American Red Cross, and they will work in their alive and well websites to help facilitate family reunification. I'm not sure we feel that comfortable giving children's information now because we don't know who is actually going to be looking at that, and we know that people can claim children that are not theirs. And so one thing we've worked out is that we only share information through our public health, local public health, and that they will interact with emergency management. So I think that's a good question. I think that's more loose, and I think in a real disaster, you'll find that hospitals are calling each other, and they're willing, under the table, we're willing to share, who's where and who's who. But I think as far as other organizations, so like the American Red Cross came to our hospital and said, can you give us the list? And we're like, who are you? We really need to make sure that you're vetted, and how are you going to use the information of the children that have been affected by this disaster.
It sounds like the majority of your work is helping families find children. What are you also doing to help children locate their families?
So that's a really good question. I think we have not done as much in the other way, so I think you're right. So adolescents could probably help, knowing the adolescents could probably help or to search for their families too. I think we have tended to help try to think about the younger children, the children who are not going to be able to talk or not be able to share that much information, because that's been a challenge for most emergency managers. So for your middle school and your high school children, they may be able to actively search, and they would interact with our child life specialists, give that information, and then we would share it with social work to be able to try to facilitate a match. So that's a good question. Dr. Garrett, I'm so excited to hear your question.
Good morning. Full disclosure, Sarita and we've worked in this space together for about 15 or more years, but
Dr. Garrett was our Grand Round speaker last year.
And they let me back in the building. But thank you, great presentation. This is really interesting to see how this continues to evolve, and I really liked how you put it in the context, of Katrina all the way up to the border crisis in 2018. It's the same problem in a different sort of paradigm. So I'm going to ask a quick question. It sort of pertains to your second to last slide, which was, I asked a question on a national survey about 12 years ago about kids and RFID chips. And I'm going to hijack your room for 15 seconds and tell you that, God help me, I just got a puppy last week, and it was $20 and a 2-minute procedure to put an RFID chip under this puppy's skin, proof positive ID in pretty much any veterinarian's office or kennel in the United States or globally. And it's a secure database that I use to maintain who they're going to call when they find my puppy 6 blocks from my house. So I asked the question, I'm going to ask just for a show of hands. You don't have to be a parent, but put yourself in the role of a parent. If you had a mechanism such as an RFID chip that's generally considered safe and low to no risk medically, there's a bunch of other theories involved there, but is that something you would consider putting in your child as a nonverbal or pre-verbal person, something they could take out when they reach majority, but would give you 100% proof positive ID of your child? I know I would do it, but show of hands, if you were a parent or if you are a parent.
And you don't have to raise your hand.
Yeah, you don't have to, but just curious to see who might do it. I would do it. And I'll tell you the context of what the national survey found. And it was about that. It was about 10% or less. So there's a lot of privacy issues around there 15, 10, 12 years ago. And they persist now. But I think there's an avenue there worth running down as it continues to get better and more secure. So just wanted to throw that out there as another perspective. And while I have the microphone, I'm going to tell you, after 15 years in preparedness, I'm going to tell you the 2 highest yield things in preparedness that I found. Number 1, buy a gallon of bleach. It's $1.19. You can purify 15,000 gallons of surface water with 1 gallon of bleach. It's your best friend. Number 2, you were talking about memorizing phone numbers. We got a Google phone number solely for the purpose of emergency preparedness in our family. You can get a number that's easy to memorize, and you can have that number ring every single cell phone, hard line, anything you want. You can ring 20 phones at the same time. So it's an easy to memorize number. Your kids can pound that number out. You can text that number, and it will simultaneously text all the mobile units or mobile devices on that account. It's a great tool for preparedness because that way you don't have to memorize all sorts of different numbers. You just memorize one. And certainly from time in the field during disasters, it takes nothing to shut down the cellular communication system. It takes nothing to jam up text messaging. You may get one shot at making a phone call when you find someone with a landline, and you want that one phone number to count. Thank you.
No, thank you. And that's why I said, in the audience, because I think there are other ways we can do this. And I'm not the only expert. So thank you, Andy.
I have a question for you. At your institution, there's a lot of pediatric trainees as well. Have you guys involved them in these efforts? And do you have a plan to incorporate them in any kind of disaster response drills? So
that's a great question, because actually every year we have snowstorms where it limits our entry into Boston. And so I'll answer in this way. Our chief residents after the Boston Marathon bombing came up with a way that they could first account for the safety of their own people, and then ask the question of where people would need help or if people can't come in. So I think it's actually published in Pediatrics, their plan, where I think it was a Google shared document similar that first the senior residents know that their team is safe, and then to have a volunteer who could come in to help. So that they've integrated that plan. I think disaster-wide for the whole hospital, there's residents play a really important role within our hospital on the ward, also in the emergency department. So we haven't gotten to the granular level where we would ask for residents to come help in the emergency department yet, but we could see that happening. But I think first it's really thinking about your residency program. How do you make sure everybody's safe and accounted for? And then if there are people that are able to help, how do we integrate them? But we have to be careful, because what happened in the Boston Marathon bombing is everybody came to help. And that's great. We actually didn't need that much help. There was only 7 people that came to our hospital, thankfully. But then what about the next day and the next day? And you tire out really easily, so you really want to reserve your workforce and make sure that it's evenly dispersed after a disaster.
Any last questions? Okay. So Rita, thank you so much for joining us here at Children's National. I think you left us a lot of room for thought. Certainly, we've done a mass tragedy drill not too long ago. Last year, we did a mass fatality drill, which also challenged this entire system in dealing with matching deceased patients.